Very good. So I guess you get your coffee. The next session is going to be quite interesting. There was a lot of exchange of email between Yves and other people in the panel and outside the panel. I would say that this session is his baby, yeah? And he wants to discuss the left main bifurcation stent sizing. As you could see, it's very short presentation, 5 minutes, 7 minutes, and so on. Then after 4 talk, we will have some discussion. Then we will start again with short talk and have some, again, discussion and finally conclusion. So at any time, Yves can interfere and say, no, you did not understand what I want to do, because it is his idea and his baby. Okay, so the first we have in the panel, maybe you can introduce yourself. It's the most easy. Take the microphone. And then we are...
Dr. J.S. Dugal from India.
Okay, the next one.
Hi, I'm Paul Morris from Sheffield in England.
Very good.
I am Jung-Min Ahn from South Korea.
Yeah, you forgot that he was with me 2 weeks ago.
I'm sorry.
Okay, good. So the first speech will be intravascular ultrasound optimization criteria for left main coronary artery stenting in pursuit of the magic numbers. And that's Sripal, Bangalore.
Thank you very much. Can you guys hear me?
Sure. Yes, we see the slide.
Okay, fantastic. And thanks for having me on. And this sounds like an amazing session. So I'm going to just set the stage in the 5 minutes I have in terms of intravascular optimization criteria. These are some of my disclosures as it relates to this particular talk. And this is based off of an editorial we wrote for Sir Cardiovascular Intervention along with Akiko Mehra for the study by Kim. Dr. Kim will be presenting later today. Just to set the stage, I mean, we all know, I think this crowd is very familiar with the data on intravascular imaging. So we published this data looking at intravascular imaging versus functional guiding versus angiographic guidance. And this is kind of the summary of all of the randomized trial data for the ACS subgroup. And clearly, intravascular imaging is the best modality for reduction of all cardiovascular outcomes, including CV death and stent thrombosis. And this was also true in the non-ACS stable coronary disease subset group of patients where intravascular imaging is the best. I was part of the ACCHA revascularization guidelines, and back then in 2021, we were still waiting for a few more trials on intravascular imaging. And of course, I mean, many of us strongly felt it should be class 1, but overall consensus was we went with the class 2A for post-PCI optimization, specifically for left main or complex coronary artery stenting. And more recently in the 2024 ESC guidelines with all of the accumulated data, I feel like it's absolutely the right direction that it's a class 1 level of recommendation A to use intravascular imaging for complex lesion, in particular left main stem true bifurcation or long lesions. So this leads us to intravascular ultrasound optimization for left main PCI. Some of the nuances to consider as we hear about the rest of the speakers are, can we come up with one single set of magic numbers? And what we had so far is many different criteria, but the most prominent ones I have it here is criteria for what we used to call Western versus non-Western world or Asian and Caucasian patients. For Asian, the data from S.J. Park's group, the 5, 6, 7, 8 rule was typically considered 5 millimeters square for left circ ostium, 6 for LAD, 7 for the point of confluence, and 8 for proximal left main. And in terms of the Western world, this is data from Excel criteria for the Caucasians, and the thresholds MSA area criteria were larger, 6, 7, and 10. As we think about this, and if you look at back in the data for 5, 6, 7, 8 rule, This was based on angiographic restenosis at 9 months, and if you use that criteria, and as was shown in this paper, under expansion versus no under expansion clearly predicted MACE-free events and also TLR-free events. But a longer follow-up of this particular study, now reporting 5-year MACE outcomes, shows that the 5, 6, 7, 8 rule may not do as well as it did for 9 months angiographic criteria, and we may have to think of larger criteria, larger size criteria. For example, here for the circumflex, it's 6 millimeters square, LAD is 8, and left main is 12. So from 5, 6, 7, 8, so to 6, 8, 12, closer. It's closer to that of the Excel criteria. I think, and I think we'll hear more about this during the later talks. The other thing to consider is, I mean, this is one such example. If you look at minimal stent area and continuum of risk, here is IVUS MSA criteria as continuous variable and risk of events, whether it's a MACE or TLR. You can see it's continuum, and that there is a threshold. So we're trying to find a categorical threshold for a variable which has a continuous risk. And we'll come back to this at the end of the end of this. I also showed the Excel criteria. Akiko was telling me that that the manuscript is still in the works. They're trying to refine it. But what I want to point out from all of these criteria is, if you look at the Excel criteria, the sensitivity and specificity tends to be modest. I mean, this is around 50% sensitivity and specificity criteria for even this 6, 7, 10 criteria from the Excel trial. Now, of course, other trials have looked at various different criteria, but all of these have been applied retrospective. So in other words, taking data which is where investigators were not asked to chase after a target MSA and looking at optimal criteria. So here is data from the Noble trial looking at 224 patients who had post-PCI IVUS, and this was analyzed per core lab. And the highest tertile left main stent MSA, which was 13 millimeters square or greater, had significantly lower left main TLR compared to the first tertile. Then moving on to, so whatever I discussed so far were absolute thresholds. What about relative thresholds? So interestingly enough, I mean, there are a number of studies which have looked at the relative thresholds. So here is the IVUS Pro criteria, looking at IVUS optimization, the ostial and mid shaft by using a relative criteria. And this relative criteria is based on reference lumen area. It's a 90% of the reference lumen area. And the same for distal left main based on reference lumen area.
You hear the music of Star Wars because your time is over.
I think I may have exceeded my time, so I will. Sorry, yeah.
I agree that it's very intimidating, this music, you know. When you hear that, you say, my God, I'm in the back shape, yeah.
Yeah, that's what I thought. They were giving me a warning. But anyway, so I have just 2 more slides to end this.
Go ahead.
So, you know, based on all of these, so the existing criteria are ones shown on the screen, 5, 6, 7, 8 Excel criteria. There is also a relative MSA criteria. So what we proposed in this editorial is the minimal, if you're using an absolute threshold, the minimal based on all of the accumulated data should be 6, 8, 10. And the optimal is perhaps larger, 7, 9, 12. But if the caliber of your artery is small, perhaps use a relative MSA criteria. And this MSA criteria should be based on vessel area at the MSA site. So this 40% is the MSA relative to the vessel area there. So just to summarize, clearly what the data currently suggests, larger absolute MSA is associated with better outcomes, and it's on a continuum risk. But we definitely need to establish safety threshold, because the last thing we want to do in the left main is cause a vessel rupture or perforation. And relative MSA threshold may be useful in patients with small caliber arteries. And when we talk about relative MSA threshold, is it relative to the reference lumen, which should be 80 or 90%, or should it be in reference to vessel area at MSA site, which typically should be greater than 40%? One of the things as we talk about is to also think about the fact that we are using some of the data and retrospectively analyzing them using achieved MSA. And clearly, if you have a patient where you can achieve a given MSA compared to a patient where you tried everything you cannot achieve, it's for a reason. It's possible that when you can achieve it, it's more lipid plaque. When you cannot achieve it, it's heavily calcified fibrotic plaque. And despite all the plaque modification you've done, you may not be able to achieve it. And those patients are likely to have worse outcomes because they also have other risk factors, maybe renal disease, etc. There is also significant underrepresentation of patients with calcified coronary arteries needing atherectomy, and safety and efficacy thresholds are unknown and needs to be tested in future studies. Thank you for having me on.
Very good. So stay tuned. We will go the 4 talks in a row without discussion in between, and then we will have a common discussion. So the next speaker is Tatsuhiro Fujimura, and the title is Stent Expansion Indexes to Predict Clinical Outcomes, an IVUS substudy from ADAPT-DES.
Thank you to Professor Serruys. Good evening, everyone. I'm very happy to present my study at the historical EBC meeting. Today, I'd like to talk about stent expansion indexes from ADAPT-DES. As you already know, there are some intracoronary imaging findings at the post-procedure. Among these, MSA is a powerful predictor of clinical event. The cutoff value was 5.5 square millimeter in the previous report. However, MSA is limited by vessel size, and the cutoff value may not apply to different population. Therefore, stent expansion is considered. The conventional stent expansion index, based on music criteria, has been used in many prior studies. However, it is not always useful due to not simple vessel morphology. So some relative stent expansion indexes have been reported. When I was studying abroad at CRF, we focused on the volumetric minimum stent expansion by HK model as reported by Dr. Nakamura. This index, which takes into account the side branch size and the vessel tapering, was calculated with an ideal reference vessel size by this dedicated formula, and had a better correlation with post-PCI FFR and 1-year composite endpoint compared with conventional stent expansion in Illuminate 1. However, that study was based on OCT, not IVUS. So first, we tried to demonstrate the usefulness of HK model in IVUS cohort, ADAPT-DES. Moreover, I believe the strong point of IVUS is to be able to measure the vessel size and the plaque volume. And I predict MSA with much plaque could be eventful. So we set MSA vessel stent expansion index as a new one, which is defined as a ratio of MSA to vessel area at the MSA site. Methods of this paper target was native coronary artery lesions treated with DS implantation, and the final IVUS pullback image in the ADAPT-DES study. We established stent expansion indexes as below. The diameters of all side branches more than 0.5 millimeter were measured to calculate HK model. The primary endpoint was 2-year clinically driven TLR or definite stent thrombosis. We investigated the relationship between between these stent expansion indexes and clinical outcomes. Result: 1,831 patients were extracted. There was the number of patients with and without TLR or definite stent thrombosis was 53 and 1,778 respectively. There was significant difference in sex, renal insufficiency, prior PCI, and PAD. In the lesion and procedural characteristics, 2,140 lesions were extracted. There was significant difference in ISR, CTO, lesion length, reference vessel diameter, and stent length. Unfortunately, left main cases and bifurcation cases were not so many in this cohort. However, I measured side branches in 1,956 lesions out of 2,140. This main results show that only MSA vessel stent expansion index was strongly associated with worse clinical outcome. In the two-year Kaplan-Meier curves stratified by the cutoff value of MSA vessel stent expansion index, 38.9%, there was significant difference between two groups, 5.7% versus 2.5%. This graph is stratified by MSA quartile. In the group with MSA less than 4.5 square millimeter, the group with no more than 38.9% had significantly more clinical events than the group with more than 38.9%. Discussion. I think the reasons why the MSA was not a predictor of clinical event in this cohort is that the MSA was optimized with IVUS. Because the average of MSA was 6.2 square millimeter, it was good stent expansion. The stent expansion criteria are frequently not achieved in any IVUS study and trials. I speculated the reasons are not only due to lower balloon pressure or smaller stent and balloon size selection, but also due to insufficient lesion preparation before stenting, such as calcium reduction with developing devices and plaque volume reduction with PCSK9. Recently, AI IVUS has become available, making it easy to check MSA vessel stent expansion index. So I hope that the MSA vessel stent expansion index will be adopted as one of the intracoronary imaging findings at the procedure that can predict a clinical event. A conclusion. MSA vessel stent expansion index was superior to traditional stent expansion indexes in predicting two-year clinical outcomes, especially in lesion with a small final MSA in the ADAPT-DES study. Thank you for your attention.
Thank you very much. So, we are only 4 for the first session. Why you don't join us? And the first speaker here, we have 3 seats, and Sripal is on video. Okay, so we will have that intense discussion later on. Then we have Jung-Min Ahn, optimal minimal stent area and impact of stent under expansion in left main upfront to stent strategy.
Thank you, Dr. Patrick Ray. My topic is optimal MSA and impact of stent under expansion in left main upfront to stent technique. So to begin with, I'd like to say that just doing intracoronary imaging in left main stenting, insertion of imaging catheter is not easy, so you need some pre-lesion modification. It makes your procedure improved, outcome improved. Once you know the intracoronary imaging and then vessel size and geometry, you can do your procedure totally depending on the imaging findings. So in addition, once intracoronary imaging is performed, try to achieve the minimal stent area criteria before finishing procedure. This is what I'm going to talking about. So previously, we published data 5, 6, 7, 8 criteria, but this criteria is derived from the heterogeneous patient group, the crossover and two-stent and first-generation DES against the 9-month instant restenosis. Another criteria we have nowadays. But I think we need some definite, more robust criteria in patients with a very heterogeneous population. So we included a patient only who underwent two-stent technique by the crush technique. So last several years, we included around 292 patients that underwent two-stenting crush technique and evaluated IVUS both sides, LAD and circumflex. We enrolled in this study. Patient age is 64, diabetes is 1/3, and mostly the true bifurcation patient. And then pre-lesion modification was done in 86, and post-dilatation with the NC balloon in main branch, side branch is 89 and 85%. The 100% final catching balloon dilatation was done in this population. And patient with a MACE or without MACE, only difference is the minimal stent area. Different from the previous talk, the stent expansion index was not associated with the increasing risk of MACE. So we evaluated LAD ostium, circumflex ostium, and distal left main. So this is distribution of minimal stent area. The distal left main 10.8 median value. Proximal LAD was 8.0. Circumflex ostium is 5.8. So this is the ROC curve and relationship between the minimal stent area of distal left main and adjusted hazard ratio. There is no significant difference between. There is no significant relationship with the MACE and distal left main minimal stent area. But the LAD ostial minimal stent area was significantly associated with the 5-year MACE rate. And circumflex ostium also significantly associated with the 5-year MACE rate. Very linear relationship between the minimal stent area and MACE risk. So above the threshold or below the threshold, the left main is 11.8, LAD is 8.3, circumflex is 5.7, but left main no progressive value. So I believe that LAD and circumflex total vessel is more important than the mother vessel, I think. So we grouped the 3 categories. The group 0 is no under expansion. Group 1 is under expansion in LAD or circumflex. Group 2 is both under expansion in LAD and circumflex. So only patient with both under expansion in LAD circumflex is associated with the MACE or coach death and myocardial infarction, target vessel revascularization. This is actually summary. When you evaluate the circumflex ostium, LAD ostium, and this left main, the LAD ostium and circumflex ostium was associated with the MACE, and both under expansion is associated with the increased risk. So I think this study suggests that the operator should aim to achieve the sufficiently large minimal stent area in left main two-stent technique. In addition, the minimal stent area values we propose here might serve as a benchmark for the IVUS-guided optimal upfront two-stent technique with the crush technique to obtain the favorable long-term outcomes. So I'd like to briefly introduce our unpublished data, provisional stenting. So around 800 patients, we pull back the IVUS after stenting, and then we evaluate the minimal stent area. So we evaluated LAD ostium, distal left main, then proximal left main. The median value is 11.6, 9.9, 8.5. This is the cutoff value of the proximal left main, 11.4, above and below, associated with the long-term outcome. And distal left main, 8.3, above and below, associated with long-term outcomes. And LAD ostium, 8.2, above and below, associated with the long-term outcome, even after a simple crossover stenting. So we grouped the 3 groups similar to the previous presentation. So under expansion in the both at least two underexpansion associated with a higher risk of MACE or coach death, myocardial infarction, and target lesion revascularization. So I'd like to suggest the new IVUS MSA criteria for left main bifurcation stenting. 5678 is based on the 9-month ISR. But nowadays, our new analysis is based on the 5-year outcomes. One stent is 8811, two stent is 6811. So this is my summary. Intracoronary imaging plays an important role in left main PCI. Imaging itself is not associated with better outcomes, I think. Additional effort for more optimal stenting based on the intracoronary imaging may lead to better stent and patient outcomes. 5678 criteria were based on the 9-month ISR and should be considered a minimal requirement. And new hour criteria 6811 are based on the 5-year MACE and should be a target goal to achieve. Thank you for your attention.
Right on time. 5 seconds you have. Bonus of 5 seconds. Okay, so the next is Sunao Nakamura, impact of stent expansion index on stent failure after left main stenting. It's always entertaining talk. That's my experience over the years.
Thank you very much. So actually, this is not my paper. Actually, my junior's paper. Actually, anyway, junior to me.
You look a little bit young on that one, yeah.
Okay. The title is Impact of the Stent Expansion Index of the Stent Failure after the left main stenting. Actually, he used the stent expansion index calculated by the MSA divided the reference vessel area. Anyway, of course, this paper is followed by the his paper. Anyway. And we use a conventional stent expansion index. This is a flow chart. And we have 1,000 patients. Actually, this is only the New Tokyo Hospital data, 1,000 left main data. So among them, we have picked up the 342 patients with a complete IVUS data. And then divided 3 groups, so greater expansion index. And then finally, we compare the high expansion index group and the low and the intermediate expansion index group. This is the histogram of MSA and the expansion index. About the expansion index, the low and the intermediate and the high, thus finally we compare the high expansion index group and the low and the intermediate expansion group. Actually, this is the result. Actually, the TLFR and the TLR high expansion index group show the better clinical outcome. Anyway, but if you look at the baseline characteristics, look at this. The low intermediate group have a higher incidence of peripheral artery disease, and the dialysis may be double, and the insulin user double. While the kissing balloon inflation and the double stenting surgery are actually very low, and the clarification the same percentage. How about with calcium lesion or without calcium lesion? TLF and TLR, calcium lesion, the high expansion index shows a better clinical outcome. And also look at the baseline characteristics. Calcification group, calcification line and a low intermediate line, insulin user triple. And the chronic kidney disease may be much higher, and the dialysis maybe triple more than. Actually, dialysis is very important. Anyway, this is a CKD or without CKD. CKD shows a TLFR, TLR, high expansion index group shows a much lower incidence. The baseline characteristics also. Insulin is actually almost double. Dialysis more than double. Long intermediate expansion index group. This is the predictor of the TLF in the patient population of the calcium lesion. Anyway, high expansion index show the great predictor of the TLF. negative predictor TLF, and also the CKG. This is the conclusion. High expansion index group show the lower TLF than the low intermediate expansion index group. So this expansion index show associated with favorable clinical outcome, the PCI for disease. This is the study limitation. This is I thought and then highlighted. Retrospective study, this is the accidentally determinant selection bias, which may lead a big background difference in the two groups. Very long observation, low angiography, and we could not evaluate precise severity culture region correlated with clinical outcome. Still question. Maybe only the stenting, not only the stent expansion index, presence and location, the classification, systemic factor, or anyway device or something like that. This is the case of a severely culture region, ostium, the LED. Plotted calcium, the ceiling on the left main. This is the good target of the rotor, good target of the rotor. So we did, and then very beautifully open up. But 9 months later, we have a severe stenosis. Shrink of the stent site due to maybe record a big calcium. Already we have a paper. And interestingly, this is the new Tokyo hospital data, PCI with a rotor with heavy calcium, unprotected left main. Look at this. In the case of HD, high percentage of stenosis. No HD, it's okay. I think we should take into account with the patient systemic condition, especially CKD, dialysis. And how about the calcium nodule? This is the case of a significant IS, big calcium nodule. We did with IVUS Diamondback system, and then the Diamondback works, and Ballon stenting, beauty open up. Very beautiful, but 1 year later, patient because of severe heart failure, the patient was sent to the bypass because we know the eruptive type calcium nodule has a very worse outcome. We should very care. Stenosis in the left will lead the patient collapse. And also, we need to know the characteristics of the each device's rotor, Diamondback, shockwave. Actually, I talk later this. And each device has a good target or weak target. Not easy. Expansion index out of retinal sensitivity may be one of the predictive factors, but there are several important factors related to vascular outcome. Maybe we should search the hidden determining factor. So I thought my talk was before Jung-Min Ahn. So I just let's look forward to the Professor Jung-Min Ahn presentation. Thank you very much.
So I have come to join us here. There's a nice seat for you here. So I think that, as usual, we were somewhat confused to start this session, and at the end we will be probably confused at the higher levels. At least that will be the big progress. So we should, I think, see the speak one by one, have the comment of the panel. So the first paper was by Sripal. Who wants to make a comment? I can warm up and say, I mean, what he used frequently is this cubic spline curve, and then he take one value, which is the point of conversion in the cubic spline, and he used that as an average treatment effect, and he said it's 0.2 millimeter. But I must say that today in our medicine, we try to personalize. We don't use one value. I know it's easy because everything in the lab is binary, I do or I don't do, but I think it's, like he said many times, it's a continuum and should be used. So the question that I have, and I've been beat up by this kind of concept using a cutoff criteria. For instance, in the valve, you have the mismatch based on BMI, no prognostic value at all. There's just published a big meta-analysis. So my question is, why at a certain point not use some kind of modern physiological parameter. And I'm thinking about IVUS FFR, of OCT FFR. You have both of both group. You see that there is no more limitation to flow. That's point number one. And eventually you can see where it is, because you have on the curve of the IVUS or on the curve of the OCT, you have the drop in the FFR. So there I have to work. I don't have the proper expansion. That's just a question for the panel. Who want to attack this topic? You.
Me, hi.
Very good.
I completely agree. I think the first talk was called magic numbers, and there are no magic numbers that define intervention or no intervention for every person in every situation. I like the idea of the relative index that they proposed, but there's no magic numbers. The arteries are there to conduct flow, and so the connection between anatomy and physiology has to be taken into account.
Very good. Any other comment from the panel? Otherwise, yeah?
Questioner.
Just a quick comment. I think in the last presentation you had all these complications, right? Perforation, perforation, perforation. And I think the danger of setting such strict guidelines with cutoffs is that you will overexpand things and overtreat things, and then you will cause perforation in the sort of tiger zone, which is not accessible to the surgeon. So that's my only concern, especially in calcified lesions in women.
Okay. Yeah? Go ahead.
I was surprised, in fact, by the paper of Jung-Min. It was because in Korea, other Korean people are grown, they are bigger, they are larger, so that's why they adapted the criteria to say that it will be preserved of event. And of course, this is not true. So I was really, I'm so very, in the two groups you have, so those respecting the rules and those not respecting the rule, you have, of course, those not respecting the rule, a higher rate of event. But this is very far from 100%. So we have a difference in event. And inside this group, which is not reaching the criteria you defined, you have people that have no event. And this is related to not to a magic number, but to a phenomenon that gives you the fact that we have to reconstruct the bifurcation as it was before. This is my interpretation. So, and the second point in your work is that this is dedicated to a population, not to an individual, which is something which is complex. I agree, I have not added to these complexities physiology. See, maybe we put that this year, next year, but will be a bit more complex maybe.
Yeah, I mean, I think I see Dr. Tu, and I just mentioned before he came into the room that to have the option to have an OFR and at the same time the anatomy is quite good. I mean, that concept of MSAA versus vessel area, there is something in it. You know why? Because it's individual. And basically it remember me a little bit the expensive remodeling who get exhausted by the value of 40%. Here it seems that 38% is a value that you have to achieve. That means that that individual has a certain level of remodeling, but despite the remodeling, you try to reach that thing. That's a value for that individual. There is something in it. What do you think here?
I think it has something to see with the branching law. And what is changing, what is modifying the measurement is remodeling. Positive or a negative remodeling. This is moving the law. So if you are able to measure the media to media in non-disease place inside the same segment, you will have very quickly, will go very quickly to the branching law, either the Finet or the Kassab. So I think there is something maybe more individual and precise than the population criteria to reach.
It's interesting because left ventricular mass is very dependent on the size of the person. Actually, it's been shown that it's on a formula for all mammals, in mice, in rabbits, in humans, horses, and even elephants. And you would think that also the size of the vessel is very dependent on the left ventricular mass. So somehow we should develop some indexed vessel size dependent on the person's size.
So two comments. First of all, I think we should exclude patients with renal failure and calcified nodules. They just don't fit into one bucket because they keep on coming back. And so I don't think that's very effective in that population with calcification nodules. Second, Dr. Fujimura, you said you had an optimal stent area derived, but maybe you needed better vessel prep. So that statement is contradictory. There you have prepped the vessel well, and you had a good MSA, but you're saying the MSA is fine, but your vessel is not prepped. So I didn't quite understand your statement on that.
Yes, I fully agree with the, anyway, first question, so we, actually in my analysis, we adjusted by the body mass index. So in addition, I think, yeah, it's very similar to the patient prosthesis mismatch. So even the small size people, the large size people, adjust by the body mass. So it is very scientific or not, I don't know, because PPM is not associated with the long-term outcomes. So indexed by the body mass. In addition, I don't think we have a big difference between my coronary artery, your coronary artery, I think. So size-wise. In addition, one thing I want to say is that our all analysis come from the patient evaluated by the intravascular ultrasound, so not angio guidance. So I think, so this population may have better clinical outcomes than patient underwent angio-guided PCI only. So more important thing is our minimal stent area is just a benchmarker for better outcomes. I don't strongly say that, I don't like to strongly say that you have to achieve it, but please try to achieve this minimal stent area. Then every effort to achieve the minimal stent area may improve your patient outcomes, I think.
So we will continue. I think what is important to come back on this body mass index, because, you know, I've been beat up a few times by these things. I know big Korean with a small heart, so you see everything. And certainly in the valve, we have been beat up by the mismatch based on the BMI. That doesn't work at all. Yeah? Yves, your turn. So your topic is in pursuit of an ID.
Yeah, so I will show you the reason why you have this session tonight. So you all know this branching law. So this is the one of Finet, the Finet's formula. The Kassab, I know, of course, he explained me many times, but it's a bit more complex to calculate. And the Morris law also, which is another one. So we have shown that in many EBC. We have shown that outside EBC. I think many people knows. Maybe a bit less known is this, which is a quite rustic simulation of the result of bifurcation stenting, showing that showing different amount surface of low wall shear stress, which is a pro-atherogenic factor, as you know. And the smallest surface of low wall shear stress is following the Finet's law or the Kassab. So this led us to put in this recommendation, TCT-AP in 2012, minimize the number of DES, maximize their position, minimize overlapping, and respect the original anatomy. We are telling that, but we have, of course, not the beginning of validation. I have seen this proposition by Kang by Mayara, and I have seen this. I've read these papers for preparation of this session, and I have seen this in January with 6, 8, and 12. And well, you know, 5, 6, 7, 8 was the beginning. The Mayara was 7, 8, and 10. So I was intrigued by the increase in the diameter in the surface between LAD and left main. So I had an idea. I was in my garden. I had an idea. So I decided to take these 3 recommendations to transform the surface in diameters. For me, it's relatively easy, as you can see, the formula. So I found the diameter, and with the diameter, I decided to calculate the ratio. For the Kang work was 0.55, for my Akiko was 0.62, and for Jung-Min Ahn was 0.66. And if you have a line here, you see that 0.66 is very close to the Finet formula. So this was the point that raised me. You know, I wanted to have something clear to explain this. So, with the help of Gary Mintz, who found my idea quite interesting, I asked for a post-hoc analysis of left main bifurcation stenting. Well, I asked David Dildix-Smith and Annette Maznyczka in EBC main, but we have only 2D QCA and not intravascular imaging. I asked Jung-Min Ahn, was the only one to accept to review his database. I have to thank him very much. Eval Christiansen for IVUS subgroup of normal, considered as a too small group to be explored. And I discussed with Akiko Maera, which is not always easy to discuss with Akiko, but I have a rendezvous with Akiko at TCT. So I don't know if it's promising. José Maria de la Torre, we discussed also, but he was not seeing in his population the way to help me. I have not asked Tatsuhiro Fujimura, and I have the plan to ask COBIS registry, and why not Chinese colleagues also to explore this. So thank you very much for your attention. Before discussing, I will present what I asked to David Dildix-Smith and Annette Maznyczka. Yeah, so I asked to Annette Maznyczka to explore the effect of Finet's fractal ratio on outcome after left main bifurcation PCI, sub-analysis of EBC main. So this is a distribution of fractal ratio. So this is individual, we'll calculate for all the patients. You see that the maximum is 70 and a bit more. She looked at with the recurve fractal ratio on MACE in the whole cohort, nothing. Fractal ratio and DES in the whole cohort, nothing. Fractal ratio in the whole MI, nothing. And TLR, nothing. I was a bit disappointed. And after that, we look at dual stent. In this group, you have dual stent and single stenting. So for dual, all the the calculation were negative. For final pot or not was negative. And for a final kissing with final pot, negative again. So you have here some comparison between 3 tercile. Under 0.64, between 65 and 74, and more than 75. And for the whole cohort, no difference in any MACE, DES, MI, TLR. With final pot, no difference, and with final pot, kissing balloon and final pot subgroup, no difference. Maybe a very small signal is a trend for TLR in dual stent group. But this is not an information of interest. You see, 0.09. So we discuss, of course, this result. achieving the ratio during the left main bifurcation PCI was not associated with clinical outcome in the EBC main cohort or in subgroups with dual stent implantation, final pod performed, and successful kissing inflation and final pod performed. However, a limitation is that the fractal ratio was calculated from the minimum vessel diameter obtained from 2D bifurcation dedicated QCA. Instead of IVUS and ORCT, and was performed in only 39% of patients in ABC main. So, and in single crossover stenting, in best projection to see the two distal ostia, there is a well-known carena shift phenomenon, giving us wrong information on the true side branch lumen on the side branch. It's oval, or it's even a slit. This may explain why we were not able to measure really the surface. So I thank you very much for this. So of course I will go on if you encourage me to do it with Kiko, and why not other call for other well-maintained databases with double imaging in the two branch. Thank you.
Very good. So we will discuss that, and then we have the classical bigger is better. You know, in interventional cardiology, it has been a big topic. Don Albeim always said, mine is bigger than yours. I don't know what he was talking about, but that's what he used to say. So bigger is better.
Thank you. So 2 months ago, Yves sent me an email. So why don't you analyze the fractal ratio based on our registry? Actually, I don't know what fractal ratio is. So I studied from since then. So I analyzed bigger is better, ratio is better, bigger and ratio is better. So my answer is very straightforward. Bigger is better, but considering the ratio may be useful in a situation. So I read some articles that there are a lot of the natural geometric law, the Finet law, flow conservation law, Morage laws. So, but I found out that different laws, but practical point of view, not that different. So in this study, Finet study, I can implant just a 3 or 3 to 5 stent, no big difference, regardless of any kind of law we followed. Anyway, Finet law, so if we know the natural geometry ratio, the basic assumption, basic idea is that if we know the two normal diameters, then we can assume the other. But to prove this concept, we have to prove that this kind of number, 0.67a, whether this number has a pronostic value, or this number would be supported by the clinical data. So based on the two-stent technique, cross technique registry, 292 patients with the cross technique, we evaluate the fractal ratio. Fractal ratio is evaluated by the mother vessel diameter divided by the summation of daughter vessels diameters. So this is a distribution of our two-stent technique registry. Fractal ratio is 0.62, very different from the EBC left main registry data, because the EBC main data is around 0.70. Our data is 0.72, 0.621. And this is ROC curve. So best value to predict 5-year MACE is 0.63, around 0.63. Above the 0.63 is associated with a higher event rate. Lower than 0.63 show that the low event rate. So when you group according to total, the highest total median value is 0.68, very similar to the Finet law of fractal ratio, show that the highest event rate. the lower fractal rate is associated with the low event rate. So Cox proportional hazard model shows that the fractal ratio, higher ratio is independently associated with a higher event rate, even after adjustment by the many clinical and IVUS parameters. So bigger is worse, I'm sorry to say, in fractal ratio. So, but the fractal ratio is relative, not absolute. What is a high fractal ratio? Left main is relatively big, or LAD or circumflex is relatively small. Low fractal ratio, vice versa. So this idea we put into the under expansion and not under expansion grouping. So we grouped the four groups. The one is under expansion, fractal ratio is high. One is under expansion, fractal ratio is low. Under expansion, no under expansion, fractal ratio is high. And no under expansion, fractal ratio is low. The patient with the under expansion plus fractal ratio is high is associated with the highest event rate compared with the other groups. So expansion rate is very similar, but the LAD expansion rate is lower in the worst group. So how to apply the fractal ratio in the practice? Higher fractal ratio is associated with worse clinical outcomes in patients with coronary stenting. Cutoff value was 0.23, very different from the natural fractal ratio. The patient achieved the natural fractal ratio 0.68 was associated with the higher event rate, unfortunately. If there is no under expansion, fractal ratio does not have a prognostic value. If there is under expansion, fractal ratio may differentiate patient outcome, but I think a further study is necessary. Thank you for your attention.
Can you come back to not the last slide, but just before that, because I want to look at the last two group at the bottom there, 59 and 66. I mean, if you had there a value of 53 or 52, I will embrace your approach. But I'm a little bit puzzled by the last two groups, 7%, 5.7%, and then 0.59 and 0.66. If you make a trend analysis, I think that some of the conclusion could be different, but I don't want to destabilize the whole system because this is the idea of Yves, so I mean that works somewhat.
Bad idea. No, just to focus on the fact that you have at the bottom one group not respecting the value you ask for at the end of the procedure. One group is not big as you want at the bottom, and he has a low rate of event. Yeah. So we recruited here a population that we can be confident having this, that the patient will do better, like others for the follow-up.
So look at the lowest two curve is there is no under expansion. So once there is no under expansion, fractal ratio doesn't matter actually. Right. So yeah, go ahead, please.
Let me ask one question to the audience. Who has ever looked at the textbook of Murray published in 1947? That's the last time that he published a book. Somebody here? I've seen the first page. Okay, so the first sentence in that book, that was my favorite, in 1947, I was born on 1947, so. But that book, the sentence is, what comes in, comes out. That's the whole principle of his life. He was interested in the coronary artery, but he was also very much interested in the heart, you know, what comes in the right atrium, right ventricle, etc. What comes in, comes out. And his great interest in physiology was about shunt. Every time that it is not comes in, comes out. So I think it was a brilliant concept at a certain moment, and and Ghassan has certainly pushed that concept to the very extreme and refined. But is that really essential for what we want to resolve? I mean, today I'm a little bit pleased by the approach of MSAA versus vessel. Why? Because the 38%, for me, it's a kind of Glagov value, you know? So if you have that value, you're okay. So I would like to see more clinical data based on that, because the big advantage is a kind of internal normalization. It's a value for you, Yves, it's a value for me. We may have different remodeling, different level of remodeling, but it's normalized for the individual. So that might be something useful. And the Glagov is unbelievable. Still today we have published a paper on Glagov based on a multi-slide CT scan. Really at 40%, you see the lumen going down. Okay, because apparently the Maasai guy in Africa or the guy western of Asia, they all do the same. At 40% of plaque burden, the lumens start to drop. So maybe there is something in this ratio. I just would like to have more comment about that. Yeah, ask us.
Ghassan, are you here? Do we have Ghassan Kassab live?
Patrick, I would like to ask you.
Ghassan?
He is probably not anymore online.
Not branch? No?
Hello?
Hey, Ghassan. Yeah.
Yes, I can hear you. Can you hear me?
Yeah, I hear you very well. So I was maybe not using very well what you teach me, but do you think, having seen what we have seen here, do you think that the objective of the treatment is to restore the initial anatomy? I mean, following some branching law. Is it the good branching law, Finet's law, or we have to test, for example, with your Kassab formula?
So before I answer that, maybe let me just point out an observation I made. I think it's important to understand that Finet's rule only applies to a Y bifurcation, meaning when the diameter of the two daughter vessels are approximately the same. If you have a T bifurcation or where the daughter vessels are of different diameters, Finet's rule, the fractal rule, breaks down. We've shown that clearly based on lots of experimental data as well as theory. Murray's law only applies rigorously to T-type bifurcations. It breaks down when you're looking at Y-type bifurcations. HK law is the only rule that applies for the entire spectrum. We've shown that back in 2012 and subsequently, and I forwarded to you the chapter from the new book, Yves. We actually uploaded a cardiac calculator to make calculations of HK rule very simple, meaning you put in for a bifurcation 2 of the numbers, you get the third. If it's a trifurcation, you put in 3 of the numbers, you get the fourth. Having said that, I think with your data analysis, I would encourage you to go back and reevaluate your analysis based on the HK rule. With that, I know Finet's rule is simpler because it's an algebraic calculation, but that's the reason I uploaded in that URL, cardiac-calculators.com. It's a free app, you just put in the numbers and you get that back. Having said that, let me try to answer your question. What we've shown is that if you try to restore a bifurcation with dimensions, you can't just focus on one vessel in that bifurcation because it's a system. And that left main has to bifurcate the flow. Exactly, to what Patrick just said, what comes in has to come out. There has to be harmony between what comes in and what comes out. Meaning, if we don't obey that nature's design, the way it was intended initially, that we've demonstrated, you're gonna have flow disturbances. You're gonna have regions of low shear. We're gonna have high oscillatory shear index. We're going to have high wall shear stress gradients. So of course, my bias is that we have to respect that bifurcation design in a way that nature intended it. And unfortunately, what I saw in some of the bifurcation, in some of the presentations, and by the way, the background noise, I have to admit, I didn't hear half of what's been said. My conclusion is we ought to relook at that data, maybe with a kind of a more generalized analysis.
Thank you. So do we have time for to show what time is it? Thank you, Ghassan. I will try to get from my friend Jung-Min a reanalysis with yeah. We will move maybe to Ikichi presentation.
Okay, thank you very much. Dear Chairman, thank you for the invitation to present at the EBC 2024 meeting. The title of my presentation is Stent Size Selection in the Left Main. My disclosure. The measurement of jailed side branches in bifurcation region stenting remains a matter of debate, with no clear consensus established yet. Incomplete apposition in the left main has been observed, leading to disturbed blood flow. To avoid such risk and achieve proper revascularization, selecting the appropriate stent size is essential. Now, I will go through each step for this flowchart, explaining the rationale and technique behind the safe and effective stenting of left main bifurcation region. This step prepares the region for low pressure stent deployment by ensuring adequate expansion. Techniques like scoring balloons, debulking, and high pressure dilation help create optimal conditions for smooth stent placement and proper apposition. Here, I will explain the rationale for selecting the stent size based on the proximal diameter. This slide compared two synergy stents, 3.5 on the left and 4.0 on the right, deployed using the same condition in the same left main bifurcation model. The goal is to evaluate the degree of the complete apposition in the left main shaft between the two stent sizes. The red part shows the incomplete stent apposition area at the left main shaft. Despite identical KBI technique and inflation pressure, there is a difference in incomplete stent apposition volume based on stent size. This slide clearly shows that by selecting appropriate stent size, we can significantly reduce incomplete stent apposition in the left main shaft, bringing it close to zero. This highlights the critical importance of choosing a correct stent size for achieving optimal outcomes. Now, I will explain how to address key issues during the stent deployment. First, we focus on low pressure stent deployment, which is used to avoid damage to the distal vessel after stent placement. This slide demonstrated that even with 4 mm stent, safe deployment at 4 or 6 atmosphere with multiple inflation is possible. By using the stent delivery balloon, the distal side can be maintained around 3.2 mm, minimizing the risk of injury. 4.0 mm stent can be safely deployed in the small distal vessel with planned expansion, avoiding overexpansion or displacement. However, effective POT is crucial for optimal stent expansion and apposition in the proximal bifurcation, where incomplete apposition is inevitable. For safe and effective POT, the key requirements are selecting a high-pressure short balloon sized to the proximal vessel diameter, and it is crucial to ensure the direction of balloon expansion is carefully managed. On the left, POT was applied from the bifurcation to the proximal side, causing significant longitudinal stent deformation due to the balloon wings pulling on the stent. On the right, POT was applied from the proximal side toward the bifurcation. Minimize deformation as both ends of the stent were well secured. We recommended proximal to bifurcation method for better stent stability and reduced deformation. After low-pressure stent deployment, incomplete apposition may occur in the distal segment beyond the bifurcation. Additional post-dilatation with an optimal size balloon is often needed, and the pre-dilatation balloon can sometimes be reused. This complete treatment, as we have seen even with stent from the same manufacturer, the outcome varies based on the size selection, highlighting the importance of choosing the right stent size. This is a large left main bifurcation model, but clinically, this size is not uncommon. The image shows the final result following the protocol we have outlined so far. It is clear that maximum expansion capacity of the stent plays a crucial role in the outcome. Megatron shows us superior performance, and Synergy 4.0 also performs equally well. Now let's move on to consideration when side branch dilatation is necessary. There are several important points to keep in mind to ensure the integrity for the main vessel stent during this process. Regardless of the stent design, the main vessel stent is elongated in the longitudinally when the side branch is expanded only.
Yeah. We should, yeah.
Once longitudinal deformation of the stent occurs, it cannot be corrected. Therefore, preventing this deformation from the outset is crucial. In this new variation of the kissing balloon inflation, the balloon in the main vessel is inflated first to explain the entire stent, minimize longitudinal deformation of the stent strut. Afterward, gradually side branch expansion is performed using the optimal side balloon with pressure of 6 to 8 atmosphere applied repeatedly. This model shows the left main bifurcation where the stent has been deployed toward the circumflex, and the sequent kissing balloon inflation has been performed toward the LAD. Although the image has some limitation, the result choosing match to the expected outcome of the procedure. Today's my summary and my key takeaway. Thank you very much for your attention.
I think that the message of this last presentation is quite clear. Don't take two small shoes for a big foot. I mean, that will not help. So I think it's a clear message. Maybe we should now review the session. What did we learn? I think that we start by trying to find the magic numbers in the main stem, in the LAD, and in the circumflex. I think that's what we have seen in the first talk. And I think that the magic numbers applicable to Mr. Everybody does not exist. I think that's my feeling. You have the small guy, the big guy, etc. I don't think that the normalization by using the BMI will be successful. That's my experience over the years. So that was a little bit the first part, the first type of talk. We tried to to introduce some physiology of some modern assessment. And I said I was pleased to see Dr. Tu in the audience and try to remember the presentation of Yoshi Onuma this morning showing this QFR going down step by step, and some technique are underestimating and some technique are correct. Apparently there was a great similitude at the level of the main stem between the Murray QCA, I would say, the Murray QFR, and the FFR-CT. That's a message I got this morning quite clearly. So in our job, we like to do some imaging, but we like to have finally no pressure gradient between the main stem and the two branch. So I think that probably what we are going to see in the future, more of these combined imaging giving you a physiological information. I mean, in many fields we start to see that. I don't see why we would not see that in the main stem. And we all agree that the ostium cannot be evaluated by the OCT, but the rest, the bifurcation very well. I mean, high quality pictures, you have to increase a little bit the flow, and you have the physiology and the anatomy. I was a little bit charmed by the concept of MSAA versus vessel size. The problem is that the usual OCT does not see the EM. I must say that I'm completely ravished by the spectra wave, which is a diameter of scanning of almost 16 millimeter. So you see the whole EM, you see the whole media, and you all even see the tissue outside the vessel. It's a kind of IVUS assessment, but in OCT. I mean, it's quite amazing. In Europe, we will not have access for the technology. It has been changed now, United States first and Europe second. It used to be Europe first and American second, but it has changed. That's the way to do. That's a little bit the message I have today. So these 38% MSAA vessel size, I would like to see explore in the sense not too much in physiology, but in clinical outcome. I mean, what does it mean if you reach that value? Because that's a value which is normalized for you and me, Yves, so we don't have to use a number coming from outside. And there is a similitude with Glagov, which is always something which is now almost 40 years old and all done all the time. Any other comment of any? Yeah.
To Yutaka, do you you have completed the work that you have presented last year, so it was very interesting. Do you plan to make a clinical validation of your choice?
Clinical?
I mean the trial.
And
The old way to perform with distal to proximal versus the choice of the proximal segment as a stent to do the crossover.
Yes, yes. Usually, but today's presentation I usually performed for clinical case. Maybe almost all cases will perform such like this step, and there is no problem. So I have to plan to this some study for the to forward, I think.
Okay, I think that we are coming to an end to this session. We have to thank Yves. We force us to think and to question the things who seems to be stable, established, but when you scratch, you see that it's maybe less strong that we do. I mean, Ghassan has a very profound comment. I mean, you cannot just say it's what comes in, come out. It's much more complex, shear stress, malapposition. There is today 4 or 5 different types of shear stress if you have a T of a Y, etc. So I think we will come back on that concept, but we need to be supported by clinical data. Without clinical data, there is no point to impose a criteria of a value if it's not to do something good in the patient. Thank you very much, everybody. I think we have to go to the next session.
And a big thank to Jung-Min, if you are ready to go on with your Kassab. And thank you. You were the first to accept to review this. Thank you.